Hello and welcome to Project First Line, the mini-series podcast on infection prevention. The Arizona chapter of the American Academy of Pediatrics is proud to partner with the American Academy of Pediatrics and Centers for Disease Control and Prevention's Project First Line to bring you this podcast series. I'm Dr. Sean Elliott, a pediatric infectious disease specialist with Tucson Medical Center, Professor Emeritus of Pediatrics at the University of Arizona College of Medicine, and long-term contributor to infectious diseases and immunizations topics at the Arizona chapter of the American Academy of Pediatrics. I do not have any financial relationships or conflicts of interest, and I have no interest with any ineligible companies to disclose. So this is session number 2, discussing perinatal hepatitis C virus, and session 1 was on congenital syphilis. Session number 3 will be updates on our dear friend COVID-19 and SARS coronavirus 2. But today we're going to be talking about hepatitis C transmission from mother to baby. To sort of set the stage, as I imagine you know, certainly but in following the media and perhaps journals, that hepatitis C is a very significant occult, meaning not typically recognized infection in many of our men and women of childbearing age. And this unfortunately has to do with not recent events, but back into the 70s and 80s and our baby boomer population, where there was extensive unrecognized sexual transmission of hepatitis C. And it lives quite quietly. So unlike hepatitis B, which is far more readily able to escalate or activate into cirrhotic liver disease, hepatitis C in many individuals can live silently and never escalate to that degree of liver disease, which might be clinically evidenced. And so that therefore means that the baby boomer population has given rise to now sexually active mothers and fathers who themselves may have been congenitally or perinatally infected. And now we're creating a whole new population of babies and even children born in the last decade or so with their own unrecognized perinatal hepatitis C virus transmission. So what do we know about the risks of perinatal hepatitis C transmission? And what we do know on the data available is that a mother who has only hepatitis C, meaning she's HIV negative, she has no other active sexually transmitted infections, and she has either latent or quiet disease, meaning her viral load, the amount of RNA particles running in her bloodstream, is not elevated, then that mother with all these low risk factors has a 5 to 6% risk of transmitting hepatitis C to her baby. And that's regardless of cesarean section versus vaginal delivery. Now, if she has some additional cofactors, for example, HIV negative, that risk increases perhaps by a full log. So it's not a significant risk of transmission, but it's certainly not zero. But anything else to mother's history may increase that risk of transmission. In fact, the most recent population data available to us, and this is a study actually out of Europe published in 2022, suggests that the risk of transmission, even in that low-risk situation, is up to over 7%. So it's a full 24% higher than initially thought to be. And that likely represents a collection of risk factors, not all of which may be recognized at time of delivery by a mother. So the risk of transmission mother to baby, while not high, is certainly not low. 5 to 6%, if you want to put this into context, is greater a risk of vertical transmission than the current risk of HIV perinatal transmission in a mother who's been treated and undergoes the protocol. So there you go. It is cause for concern. That's perhaps the one of the major reasons that we're hosting this webinar on this topic, because perinatally transmitted hepatitis C is out there and it is a risk. Now, how bad is the risk of disease? That's sort of the other part of the story. Fortunately, not bad. So, the rates of spontaneous clearance by the child, by the baby born with perinatally acquired hepatitis C, are anywhere from 25 to 40%. That's spontaneous clearance. And that clearance occurs within the first 5 years of age. So already this is the disease which is not causing significant active initial disease, and there's a fairly decent chance that it will resolve spontaneously without any intervention whatsoever. And in fact, the data coming from Europe, published in 2022 that I just mentioned, suggests that the rate of spontaneous clearance can actually be even a little bit higher. So that's really good news. The other piece of good news is that hepatitis C in baby and then eventually child is a very slow progressor, meaning that it is entirely likely that child who has perinatally acquired hepatitis C may not have any findings at all for their entire life. They may not have cirrhotic liver disease, they may not have liver dysfunction, they may not develop the most significant complication of perinatally acquired hepatitis C, which is development of hepatocellular carcinoma. But if they are going to develop cirrhosis or carcinoma or the other things, it'll typically take at least 3 decades before they enter into that time. So that's the good news as well. It gives us plenty of time to recognize and to intervene for that child who actually truly acquired perinatal hepatitis C. But to do that then, and here's where the infection prevention part comes in, we have to be able to detect the child, to detect the baby as truly having had either actual transmission or a risk thereof, which again, as we look for congenital or perinatal transmission and preventing that, right, infection prevention talk, we have to focus on the mothers and the fathers as well. So while again this is not under the purview of a typical pediatrician, we certainly can advocate for and lobby for increased screening of our expectant mothers, and also to increase the use of hepatitis C screening in routine adult primary care visits. How about that? Let's not just look for HIV and, prostate, hypertrophy for dads and other things for moms. Let's actually look for HIV and hepatitis C and syphilis and all the other fun stuff. So it's not hard to do, but it's a big step to advocate for yet additional screening practices in the primary care visit. So fast forward now to the mother who's known to have hepatitis C. Previously, and this is an important change which has just been going live in the last 6 months or so, previously we were able to screen baby born to that mother by an antibody test at 18 months of life. 18 months, not at birth, not in the first couple months, 18 months of life. Why not earlier with the antibody? Because mother's IgG does cross transplacentally, and we would not wish to detect a maternal positivity by screening baby too soon. We proved that this in fact does happen and did happen back in the days when we were screening our perinatal HIV exposed babies by antibody tests beginning at 12 months of life, and got the shocks of our lives when 50% of those tests were still positive, despite having had negative PCR tests. So we can screen babies by antibody tests, hepatitis C serology, at 18 months of life, and consider testing, historically considered testing, by the RNA PCR for hepatitis C anywhere from 2 to 6 months of life. Well, that was then, this is now. So late 2023, the Centers for Disease Control and Prevention came out with a new screening recommendation, and that is to screen all exposed infants, hepatitis C exposed infants, by PCR, RNA PCR, at 2 to 6 months of life. So not waiting until 18 months of life. And you might wonder why, what's the reason for the change? And the reason for the change is that by 18 months of life, a lot of those babies fell off the radar. They either moms were unaware or forgot about the history. It certainly was not part of the medical record. And so we had a whole bunch of babies who may have been hepatitis C infected who were not being picked up, not being treated, and having that same 30-year risk of developing cirrhosis and hepatocellular carcinoma. So picking them up earlier at a routine primary care visit, 2, 4, or 6 months of life, is the recommendation, so that A, we don't miss the baby, and B, we can get that baby into monitoring so that when it is time and we're able to treat them, that age is 3 years by the way, that we're already good to go. So it's about developing a relationship, and it's about not missing the opportunity to screen the baby. Okay, so how then? Let's say we detected the baby has a positive hepatitis C PCR after an exposure. How do we then monitor that baby until it's time to consider treatment? And typically what we do is every 6 or at most 12 months, we repeat a quantitative hepatitis C RNA PCR. You might know of that as the viral load, certainly if you manage babies who are HIV infected. So the viral load, just to see, how active is baby's disease, and also to track whether those numbers are decreasing and whether the infant might actually be in that 40% or higher who's going to spontaneously clear the infection, fingers crossed, right? So we follow the quantitative hepatitis C PCR every 6 months, or up to 12 months. We also follow liver biochemistries, and typically AST and an ALT, as well as some evidence of synthetic or liver function. So total bilirubin, albumin, and total protein, something like that. And those also are followed in that same time frame of 6 to 12 months. babies who have acquired true hepatitis C virus infection, perinatal acquired, will have detectable viral loads or RNA PCRs that are positive, and they will typically have transaminases, their AST and their ALT, which are 2 to 3 times normal. That is what's expected. It does not mean cirrhosis. It does not mean liver dysfunction. It simply means that, in fact, the liver is infected. But those same babies are still very likely, 40% or maybe higher, to clear their infection spontaneously. Along with that monitoring, we will also at one point obtain a hepatitis C virus genotype. So hepatitis C exists in nature in several different forms, genotypes, up to 5. And what type of medication we might choose if we have to treat sometimes depends on what the genotype is. So we would do a hepatitis C genotype and confirm that there is no risk of hepatitis B, HIV, syphilis, or any of the other potentially sexually transmitted infections which baby could have acquired perinatally. It is fine to do routine vaccinations. It is fine to do routine preventative care. Routine medications are fine. Avoiding hepatotoxic drugs, of course, but again, in the first couple years of life, how many truly are there in pediatrics? Thankfully, not many. Not that this should be a big issue, but in older patients, think the adolescent who may have hepatitis C, avoiding alcohol use, especially alcohol use disorder. And then in those children who, for whatever reason, may not have been detected until later, if their liver numbers start to climb, then they need evaluation for the hepatocellular carcinoma, typically by some radiographic assessment of liver fibrosis and then potentially liver biopsy. So clearly when we get to that stage, you'll have additional subspecialists involved. Presumably a hepatologist, a pediatric hepatologist would be key to that, as well as likely an infectious disease specialist. So that's the monitoring. That's what we do to follow these babies. And in terms of other issues, it's otherwise just routine preventative healthcare visits with those additional monitoring steps. Treatment then. Beginning at age 3, we can start to discuss treatment for that child if they are showing no signs of spontaneous clearance of their hepatitis C. Why age 3? Because the 3 combination antivirals, which have excellent efficacy against hepatitis C, are not licensed or approved under age 3 years of age. You may be thinking, oh my gosh, holy cow, I've got this ticking time bomb. This kid's got hepatitis C. I want them treated ASAP. But keep in mind, it is a very slowly ticking time bomb, and babies and then child's risk of developing disease is remote, for the next 30 years. So we've got time, people. It's okay. So beginning at age 3, you can treat with the antiviral treatments, and we'll discuss what those are in just a second. Many providers wait even until age 5, still hoping for that spontaneous clearance to occur. And again, because there's no risk, there's no loss of efficacy, there's no concern for waiting even longer, it's fine to wait for that, just because the risk of disease progression is so low. So, what are the direct-acting antiviral regimens? There are 3 of them. Again, all 3 are only licensed and effective for use after age 3. And the 3 products are, I will say their generic names and give you the product name, which may be easier to remember and pronounce. So glecaprevir, pibrentasvir, or Mavorette is a combination drug that's good for any genotype of hepatitis C, and it can be conducted as a single dose per day regimen for 8 weeks. FYI, there have been spontaneous viral clearance tests on all 3 of these products, and all of them show over 90% success rates in pediatric patients. This Mavorette drug is over 96% effective against all genotypes in the young children, and is 100% effective in adolescents, which was its first indication. So that's drug number 1. Drug number 2, so sofosbuvir, velpatasvir, or APQII, also effective for any genotype for hepatitis C. This is a 12-week regimen of a single daily dose. Then the last one is ledipasvir, sofosbuvir, and that's Harvoni, which is also a 12-week regimen. This one is good only for genotypes 1, 4, 5, and 6. So the current recommendations as such are to consider either of the first 2, depending on insurance coverage and or availability. A question which frequently comes up, because we're all used to holy cow, these are like really brand new, expensive direct-acting antivirals. How in the heck do we get them approved by insurance? Actually, these exist in the Mavorite form, actually in generic form, and many insurance companies are very willing to support the use of these drugs because they recognize the infection prevention steps of treating early and preventing that patient developing cirrhotic liver failure, need for liver transplant, or prolonged treatment with chemotherapy. So while prior authorizations are sometimes necessary and/or one has to search a little bit for the pharmacy which can create the oral pellets, for example, or the powder packets so that a younger child can take these, still there are not as many barriers to using these medications as you might anticipate. So those are the three regimens, and I've had the opportunity to treat more than several children with two of these products. And again, I'm not here to endorse one or the other, just to say they are all highly effective. The important thing is, though, because they don't come in suspension form, but the oral pellets or powder form is actually not unpalatable, and I've not had patients so far express any major challenges in drug adherence by the child. So it's of course beneficial that it's a once daily regimen and that it's for 8 or 12 weeks depending on the product. This is not forever. So amazing to me, who is a person who has treated previously hepatitis C using interferon injection regimens and all sorts of other things with limited success, that it could be so easy and so successful as this. And I'm so very happy and proud of scientific discovery to say that indeed our approach to treating hepatitis C in any age, and especially children, has become so, believe it or not, straightforward. Whoever would have thought that? So those are the regimens, those are the drugs. Typically my practice has been, and this may be something which works for you, is to start the conversations about the treatment with the parents or the guardians prior to age 3 while you're following and monitoring the viral load and the transaminases. And then to age 3, if the viral loads have not budged, or in many cases if they've increased, then it's okay to say with the guardians to say, okay, now's the time when we can treat that, where there's not a penalty for waiting, we don't get any benefit from waiting. How do you feel about starting treatment now? And 100% of my patients have wanted to start as soon as possible, just to get this done, to cross the T, to dot the I, and so that they can take that worry about their child off their worry list and replace it with other things, of course, but going forward to hopefully treat this earlier. So it can and should be a shared decision making, and waiting till age 5 or so to again give a thorough chance for a spontaneous resolution is quite reasonable. Now, again, this is an infection prevention podcast, and so let's talk about other infection prevention issues related to hepatitis C. One of the frequent questions, based on our understanding and experience of babies born to HIV-positive moms, so HIV, not hepatitis C, is that there is some concern of transmission after delivery via breastfeeding. So in this case, the data is not extensive, but it does suggest that if mother has active hepatitis C, so an elevated viral load, and certainly if she has additional sexually transmitted infections, then the risk of transmission via breastfeeding is more than theoretic. And that is a mother who should pump and toss until she gets her hepatitis C treated, or that the baby should be fed through non-breast milk means with formula. Pumping and tossing. So if mother is a recent discovery of hepatitis C, yes, her body fluids, so blood and theoretically breast milk, can be contagious to somebody who has mucosal exposure to that. Meaning the needle stick, the body fluid splash into an open sore or into oral mucosa all have theoretic transmission of hepatitis C, just like they do for HIV and for hepatitis B. So infection prevention steps would be careful handling of body fluids and certainly phlebotomy for the actively infected mother and or child. And if, though, mother is recently diagnosed at time of delivery, is commencing treatment on her own, then, while we'll still be monitoring babies should not be exposed to mother's antiviral regimen via breast milk. So they should not breastfeed at that time until mom is done with her treatment and is hepatitis C either negative or responsive. So that sort of is for breast milk and breastfeeding. For the baby who is infected and is being monitored prior to treatment, there are not any special considerations other than, again, just appropriate, careful handling of blood and body fluids as we would with anybody. So certainly would not counsel this baby be put in a bubble or a gown or masks or anything like that. There's no need for that. Parents may ask, is it okay for baby, toddler, child to play with their siblings? Yes, absolutely, 100%. So I guess I would counsel a very relaxed approach to infection prevention in this case. In the clinical setting, an obvious blood spill or body fluid spill should be cleaned up as you would with another suspected hazardous spill with HIV blood, which is, again, bleach, wiping, using gloves, hand washing. Very straightforward. Other things, as I mentioned before, routine vaccinations, including use of needles and discarding the needles from the vaccines as per protocol, which is using your sharps box and gloves, etc. Nothing special there. Really nothing else to worry about. And routine or universal precautions, such as hand hygiene before and after the patient visit, using gloves with potentially body fluid contaminated substances like a diaper or blood spill is all appropriate, but nothing special even compared to other things. So there you go. That is perinatal hepatitis C. It will be interesting to see what happens as we get further into detection and treatment of adults, of sexually active adults of childbearing age, whether the rates of hepatitis C just period go down, and certainly whether the rates of transmission and detected positives for our children also go down. I suspect that is so, but it's really too early to see any discernible effect so far in terms of population dynamics and epidemiology. The hope is, yes, of course, that would be fantastic, and we could cross this one off our list once again if we can reduce the burden of hepatitis C in the sexually active adult world. But we're not there yet, and we probably won't be, at least within my remaining career, but hopefully so in maybe 10, 20, 30 years or so. So fingers are crossed. Meanwhile, thank you again for tuning into this session of Project First Line, the mini-series podcast on infection prevention, and for thinking about perinatal hepatitis C prevention and evaluation and treatment. Tune in for the next session, which will be on SARS-CoV-2 and COVID-19, updates on what's out there, our current vaccine strategies, etc., and so forth. And as always, thank you for your support of infection prevention topics and of Project First Line. Thanks all for tuning in today.